All right, everyone, good afternoon and happy Friday. Thank you so much for joining Advocates for Ohio's Future Friday webinar series. Today's webinar will focus on 30,000 foot view of the sub-bill changes that we saw released in House Finance earlier this week, as well as our celebration of Black Maternal Health Week here in the state of Ohio, and really excited to hear from an amazing panel of speakers that we have lined up about efforts in Ohio, both at the state level, federal level, as well as a local provider to talk about what they are doing and what can be done and how you can make your voice heard and get involved in the efforts to improve Black maternal health outcomes in the state. So really excited to get things kicked off. A couple housekeeping items just before we get started. Please know that all of our slides, as well as a full recording of this webinar, will be available at www.advocatesforohio.com/webinars. About 30 minutes after we finish up today, we want to make sure we get that up and available to you as soon as possible, so you can refer back to all the great information that our presenters have put together today. And also, my name is Kelsey Berkfeld. I apologize if I missed that introduction. I'm the Director of Advocates for Ohio's Future. So just a couple minutes here on this sub-bill. We did see that first round of changes released earlier this week. I wanted to make sure we were clear on kind of the timeline of what we're looking at in the budget. Things tend to kind of be quiet for a couple weeks, and then it's fast and furious. So we are in that fast and furious time period here in the House. The sub-bill, so that first round of changes was released this past Tuesday. Amendments to that sub-bill were due today. There was opportunity for public testimony on Wednesday and on Thursday. Long hearings, lots of written testimony submitted in House Finance Committee. Advocates for Ohio's Future, as well as a number of our partners, made sure that we put in our comments on the sub-bill as fast as we could for that hearing on Thursday. So we will see another round of amendments, the big omnibus amendment introduced next Tuesday. We know our friends at the Legislative Service Commission, who are responsible for putting really the new version of the bill together and typing up all those amendments and making sure everything checks out. We'll be working very long, hard hours this weekend, so we are thinking of them. And then the vote in House Finance will take place on Wednesday, and then a full House floor vote on Thursday. So things are wrapping up in the House very, very quickly. We do know that the Senate has held some preliminary hearings on the budget bill, again, as it stands in Senate Finance, and then next week they will break out into their kind of subcommittees, track committee structure to hear from agency directors. So things are speeding up here on that budget bill. I wanted to share just a few of the changes that I know AOF has been keeping our eye on as of Tuesday. So in the Jobs and Family Services space, we were excited to see a slight increase for the Adult Protective Services line item. This will ensure that each county has at least $65,000 per year per county, which will ensure one full-time employee to handle all the cases for adult protective services in that county. We know other counties have some additional funding sources, but this will make sure that each county at least has that one full-time dedicated person. We know that elder abuse has skyrocketed in recent years, especially with the pandemic, and we want to make sure that our older adults have advocacy, have some folks fighting for them on the ground and in local communities. So we're excited to see this increase. We're also excited to see increased reporting requirements for the TANF spending plan. I know not everyone is a TANF nerd like I am, but it's been interesting to kind of track those changes and really kind of reporting on how those dollars actually get spent in that big TANF line item over the years. So we're excited to see some additional transparency and accountability. We were also encouraged to see the TANF earmark for the kinship caregiver program. I know we had a presentation on kind of children's services a few weeks ago. Excited to see that those dollars were partially reinserted into the budget at $10 million. This fiscal year it's at 15, but these dollars will help those kinship care families kind of stabilize and make sure they have what they need to make sure that they give that child kind of a stable and a healthy start in a new environment, new situation. So excited to see most of those dollars renewed. Maybe we can bump it up even more as the bill moves towards the Senate. We were also really encouraged to see that the slight increase in eligibility for publicly funded childcare was maintained in the in the House sub bill. So 138% for children, and then 150% for children with special needs. So we know as advocates for Ohio's future, we will continue to advocate for that eligibility level to start at 200% of the federal poverty level, to make sure that we allow parents to get back into the workforce and have that peace of mind to know that their kids are somewhere safe and really have a great start to learning in their childcare setting. And it's something that they can afford comfortably. So we'll be continue to advocate on that issue. 2 more quick slides, bear with me. We're also excited to see an additional bump in funding for the Ohio Association of Food Banks. This is in one-time kind of coronavirus relief dollars that are still floating around out there to really make sure that we shore up food bank services for those families who are still struggling in the pandemic. Also excited to see, and I know our first presenter, Hope Lane, had a big hand in this next development for JFS, is going to request from USDA, from FNS, kind of the federal hand, to make sure that our seniors have a little bit more flexibility when applying for SNAP benefits, to make sure that they stay on the program. We know that administrative errors and kind of the recertification process can be really difficult for our seniors. So making sure that they have this additional flexibility through the Elderly Simplified Application Project will ensure that more of our low-income seniors kind of keep those really essential food benefits for as long as possible and in a more kind of less burdensome way. So really excited to see that that was included. We did see some changes in some additional study for the Step Up to Quality program within our publicly funded childcare system. Looks like that House would like the House and Senate to take a look, kind of an independent study of the Step Up to Quality program and publicly funded childcare as a whole. And they did pause some of the steps for the requirements for quality in the Step Up to Quality program, but still kind of kept that final benchmark in place, that final benchmark meaning that all programs be rated in the 3rd tier, kind of 3 stars or higher by June 30th, 2025. So quality is still there, but we did eliminate some of those steps and some of those benchmarks moving forward. One other kind of big subject area I wanted to touch on before we move on to our more exciting presentations. So broadband access and affordability is really has been a cornerstone of AOF's advocacy. This General Assembly, we all know how important connectivity was, just a vital, really public utility moving into and through the pandemic. So we did see House Bill 2, which included a lot of funding for broadband kind of infrastructure and residential expansion in it. So right now there's $190 million appropriation in the budget bill to kind of build that infrastructure, reach some of those communities that do not have access to broadband, either through their location, so geography. We know we have some areas in the southern part of our state where that's very difficult to reach, and also for affordability. So affordability is the second part of the conversation that we are focused on at AOF, and making sure that that is also on the minds of the legislature as they move forward with these dollars, making sure some of those affordability safeguards are in the program that does get passed out of the House and Senate. So we have a couple suggestions for them, and you can certainly read those from our slides, but overall we want to make sure that we have some of those safeguards and making sure that families can afford the services when we make those expansions. And then finally, we have a couple just, did not save, a couple big additions to the sub bill. Just wanted to make a quick note of. So House Bill 1, the new school funding formula was inserted into the budget bill through the House. So this is a new school funding formula, kind of overall, a huge overhaul, will be implemented within the next 6 years to really make sure that Ohio is funding the true cost of education in Ohio. We know that Ohio's current school funding formula has been unconstitutional for pretty much as long as I've been alive, 20 plus years. So we are looking for kind of a really substantive fix. And we know that our partners in the school funding and kind of the teacher realm have kept a close eye on this legislation. I'm sure we'll see some additional changes as it continues to move through. And we also saw the proposed a tax cut included in of the sub-bill. This is a 2% personal income tax cut across all tax brackets. It'll cost the state about $380 million, which means, in essence, it's $300 million of sustainable funding that is taken away from some of these programs. Like I can think of K-12 education, public funded childcare, some other issues that could use some sustainable funding. So we will see if this stays in the Senate, and we'll keep a close eye on those dollars. We know that given the situation Ohio has been, the situation we've been in the past 12, 14, 16 months, we know that these investments are really vital, and that really we should focus them on folks who have been disparately impacted by the pandemic is really the position that AOF has and will be taking moving forward. So we know that was a very, very, very quick overview of what we've seen in the Senate, the House sub-bill. Again, we'll see another round of changes next week. We'll see even more amendments as the bill moves to the House floor, and we will be here in 2 weeks to give you a more in-depth kind of analysis of what we've seen, some more issue areas. We'll have some more AOF guests join us to really talk about what's happening in that sub-bill and what we hope to see moving forward in the Senate. So plug for 2 weeks from now. We hope to see you at 10:30 a.m. back to our earlier time. With that being said, I'm going to go ahead and turn things over to my colleague Hope Lane with the Center for Community Solutions to tell us more about Black Maternal Health Week and her work in that area. Take it away, Hope.
Sorry, I had to unmute myself. Hi, everyone. So my name is Hope Lane. I'm a policy associate with the Center for Community Solutions. This slide here just kind of highlights what the Center for Community Solutions is. It's a nonprofit, nonpartisan think tank focused on health and human service issues. Over to the right of the slide, you see our priority areas. So advancing well-being of older adults, enhancing behavioral health access, improving maternal and infant health, strengthening health and human service safety net, and supporting sound Medicaid policy. There's our website and then our wonderful Twitter account ran by our comms director, Danny Carlson. Next slide, Kelsey. So who am I? So my name is Hope Lane Gavin. Again, I serve as a policy and externals affairs associate with the Center for Community Solutions, and I lead Community Solutions SNAP policy work in addition to being a part of the maternal and infant health team. I have a bachelor's of arts in political science from Kent State University, and then a master's in political management from the George Washington University. Next slide, Kelsey, thank you. So what's up with maternal health? So women in the United States are the most likely to die from complications related to pregnancy or childbirth in the developed world. In 2018, there were 17 maternal deaths for every 100,000 live births in the United States, a ratio more than double that of most other high-income countries. So I included actually the chart to the left of your screen to show you. So you have France, Canada, the United Kingdom, Australia, Switzerland, and so on and so forth. So again, that number is more than double that of most other high income countries. This is truly one of the most urgent health crises in the United States is facing today. According to the CDC, more than 60% of these deaths in America are preventable. For every woman who dies, there are 70 women experience a near miss, also known as severe maternal morbidity. Maternal morbidity is incredibly important, and I think that in this space, it doesn't get as much attention as maternal mortality, but severe maternal morbidity, again, is a near miss, so an almost death, and it leads to short and long-term consequences to a woman's health. So maternal morbidity is just as important, in my opinion, as maternal mortality. Next slide, Kelsey. Okay, so we're here today to talk about Black maternal health. So why Black maternal health as opposed to just maternal health? The maternal death rate for Black women, which is 37.1 per 100,000 pregnancies, is 2.5 times the ratio for white women, which is 14.7, and 3 times the ratio for Hispanic women, which is at 11.8%. So again, on the previous slide, we said it was 17 per, the average rate again is 17 per 100,000 pregnancies, but for Black women, it's 37.1 per 100,000 pregnancies. So a Black mother with a college education is at 60% greater risk for maternal death than a white or Hispanic woman with less than a high school education. Black women are also twice as likely to lose an infant to premature death. So actually the white maternal mortality rate has fallen in this country from around 1990 to 2015 by 44%. But maternal mortality in the United States as a whole increased by 16.7%, making the United States the only developed country with a rising maternal mortality rate. In fact, the only countries in the world with a rising maternal death rate is the US, Afghanistan, and Sudan. Next slide, Kelsey. So why is birth so bad for Black women? So while the causes are complex and include coverage gaps and social determinants of health, which we will talk about later, such as healthcare access and quality, economic stability and education access and quality, the main and the most important driver of these disparities is racism. So you have the issue of medical bias, where Black women receive disparate care from medical professionals because of implicit biases. You have the issue of weathering. So weathering is often a term you hear in geography when it comes to rocks, right? And environmental issues. Black women literally weather caused by when faced with constant racism, discrimination, and stress leads to premature aging. So a Black woman that gives birth at 29 is at a disadvantage than a Black woman that gives birth at 17 years old because her body is weathered. And the other issue is data. Without timely and public data, it's difficult to assess where to target resources and pinpoint numbers and problems. Next slide, Kelsey. So what does this look like in Ohio? So in November of 2020, the Ohio Department of Health released the first report in several years on maternal mortality. This report covered maternal deaths that occurred from 2008 to 2016. Across this 9-year span, 109 pregnancy-related deaths occurred among white women, 63 among Black women, 6 among Hispanic women, and 8 among women of other races. At the county level, only 11 counties reported no pregnancy-associated or pregnancy-related deaths during this 9-year period. So out of the 88 counties, only 11 counties reported no pregnancy-related deaths during this time. And next slide, Kelsey. So then what's being done? So we have Ohio, there's the Ohio Black Maternal Health Caucus, which is modeled similar to the Congressional Black Maternal Health Caucus, which you may have previously heard about, which is a group of state legislators dedicated to improving Black maternal health outcomes through advocacy and through legislation. I included their Twitter and Instagram handle, and they're also on Facebook, so you can definitely keep up with what they are up to through these. And I'm sure there are some members of the Black Maternal Health Caucus on this webinar today. There's also, so the Ohio Department of Health has a pregnancy associated mortality review board. It's the PAMR board, and they review, again, the pregnancy associated and pregnancy related deaths in our state. We have the Ohio Council to Advance Maternal Health, or OCAM, Community Solutions, and ROOTT and Groundwork Ohio are all members of this council. And then we have the Ohio Collaborative to Prevent Infant Mortality, or OCPIM. Again, they are tasked with doing work as the Ohio Council to Advance Maternal Health, but the focus there is on infant mortality. Next slide. So are there any local efforts? So many communities in our state feel there's no more time to wait and waste and have taken matters into their own hands. Organizations doing great work for moms and babies around the state include, but are not limited to, Celebrate One in Franklin County, Restoring Our Own Through Transformation, which Dorian and Jessica will be on this call from ROOTT. They are amazing. Birthing Beautiful Communities out of Northeast Ohio. They cover Cuyahoga and Summit counties. There's the Village of Healing out of Cuyahoga County as well. There's the Perinatal Outreach and Encouragement for Moms, or POEM, out of Cuyahoga County. And there's Cradle Cincinnati and Queens Village in Hamilton County. So what is Community Solutions' role in all of this? So we do advocacy, research, and policy solutions. Recently, however, we have identified that for favorable birth outcomes, women need more than just access to care, but a combination of skills and relationship-based care, and that would include the work of doulas and the work of midwives. Next slide. So what is a midwife? So there is a paper series soon to be released by Community Solutions, in which I'm a part of, as well as my colleagues, Lauren Anthis, Tara Britton, and Natasha Taki Micah. So that will actually start next week, where we will be releasing one paper each week for the next several weeks on midwifery in this country and in this state. But as a quick overview of midwives, midwives are known for delivering babies for low-risk women, but many midwives in the United States are actually highly trained healthcare professionals that offer a range of services for women at all stages of life, including reproductive care, menopause care, and just general health care. Midwives are able to manage many common obstetric scenarios and complications without obstetrician oversight. Positive birth outcomes and better results compared to care led by or initiated by a physician. That one is the key, and that's the base of our research, the positive birth outcomes associated with having a midwife during a pregnancy. Midwives are very normal in many other wealthy industrialized countries, but midwifery is very uncommon in the United States due to licensure requirements that have very racist origins. Thank you, Kelsey.
All right, thank you so much, Hope. And next on our lineup is Kelsey Hopkins with Groundwork Ohio. Whenever you're ready, Kelsey, please join us.
Hi, everyone. Thanks, Kelsey, and good afternoon. My name is Kelsey Hopkins, and I'm a policy associate at Groundwork Ohio. Groundwork Ohio is a statewide nonpartisan advocacy organization that champions high-quality early learning and healthy development strategies from the prenatal period to age 5 that lay a strong foundation for Ohio kids, families, and communities. Our vision is to make Ohio the best place to be a young child so that all children have the opportunity to reach their full potential, and Groundwork is led by Executive Director Shannon Jones and governed by a robust steering committee of child-focused health and education experts from across the state. You can go to the next slide. Thank you. This is a little bit about me. My focus areas are for prenatal to age 3 and maternal and early childhood mental health at Groundwork Ohio. You can go to the next slide. So at Groundwork, we know that healthy moms are the foundation of healthy children. Whether infants are born healthy and with the potential to thrive as they grow greatly depends on their mother's well-being. To have a healthy pregnancy and positive birth outcomes, women and their infants require access to appropriate healthcare services before, during, and after birth. Next slide, please. We know that the future of our children and our state depend on what we do today. We have to support families now as an investment in Ohio's future. We can give kids a better childhood and ultimately better lives if we invest when it matters most. So investing in evidence-based interventions during the earliest years of a child's life, which is prenatally to age 5, can close gaps that are impacting low-income children, children of color, children in underserved communities, and supporting high-quality interventions in the earliest years result in things like better birth outcomes, more children reaching their first birthday, improved kindergarten readiness rates, stronger families, higher high school graduation rates, a more prepared workforce, and healthier adults with greater lifetime earnings. Next slide, please. So we know that when we invest early, these investments give us one of the best returns on public dollars you can find, with a nearly 13% return on investment. So with that, let's look at some of the investments in mothers and infants in the budget. Next slide, please. So there is a $4.3 million investment in mothers and children safety net services for the Department of Health to invest in different programs and services that support families. There's also a $25 million investment that was made in the Maternal Child Health Block Grant. Help Me Grow, Ohio's evidence-based home visiting program, is receiving an investment of $1.9 million to allow additional families to be served. On the screen is their total budget. And a $5.5 million investment is being made in infant vitality, with $5 million to be used in consultation with the Governor's Office of Children's Initiatives to support programming by community and local faith-based service providers that invest in maternal health programs, provide services and support to pregnant mothers, and improve both maternal and infant health outcomes, And then $500,000 of that $5.5 million investment is to be used in consultation with the Department of Medicaid to develop a universal needs assessment to identify and provide needed health and wraparound supports for vulnerable women. And then infant mortality health grants are to be administered through the Commission on Minority Health with up to $2.6 million each fiscal year to be distributed to up to 10 community-based agencies to support the continuation or establishment of a pathways community hub model that has the primary purpose of reducing infant mortality in the urban and rural communities with a targeted focus on disparities. And then there's $135,000 in each fiscal year that the Commission on Minority Health is to use to provide evaluation and review of the service delivery of the grant recipients. And then finally, up to $2.25 million in fiscal year 2022 has been invested for local development projects for the Developmental Service Agency to use in coordination with the Department of Health to support stable housing initiatives for pregnant mothers and to improve maternal and infant health outcomes. There were no changes that were made from the as introduced version of the budget that impact any of these maternal and infant initiatives. Next slide, thank you. At Groundwork, we have 3 budget priorities, and these are empower parents through voluntary evidence-based home visiting, supporting healthy moms and healthy babies, and keep Ohio working by expanding access to quality childcare. And to aid in furthering these priorities, we've had budget amendments introduced that speak to each one. Next slide, please. So first, to empower parents through voluntary evidence-based home visiting, our introduced amendment would increase the investment in Help Me Grow by an additional $1.9 million in fiscal year 2023. This would double the current investment made in the governor's as introduced version of the budget and provide the ability to serve an additional 500 children and families through evidence-based home visiting. Next slide. We want to support healthy moms and healthy babies by providing enabling language for the Department of Medicaid to extend eligibility for pregnant women to 12 months postpartum. This language has no cost and does not force a state policy choice or implementation. However, because of policy changes at the federal level as a result of the American Rescue Plan, which Kelly is going to talk a little bit more about in a moment, this allows the department to be able to amend our state plan without returning to the legislature at a later date. Finally, and not listed on the screen, we also had an amendment introduced to keep Ohio working by expanding access to quality childcare by increasing eligibility to publicly funded childcare to 150% of the federal poverty level. Kelsey spoke to this a little bit earlier. The as introduced version of the budget brings eligibility from 130% federal poverty level to 138%. But we know that access to quality childcare is a social determinant of health that supports women's economic mobility and the ability to care for their families. And in addition to this, recent research from the Center for Urban Poverty and Community Development found that women and communities of color experienced the biggest challenges in the loss of childcare options due to the pandemic. So although these amendments were not included in the sub-bill introduced on Tuesday, and the investments currently remain the same as the as introduced version, we're working to get them included in the omnibus amendment in hopes that reconsideration will be successful. Next slide. In fulfilling Groundwork Ohio's mission, supporting its coalition-focused work and operationalizing equity in our work, we have initiated and are beginning to operate the Center for Family Voice, which is a center for excellence at Groundwork dedicated to authentically engaging Ohio parents and families in the policies and practices that impact the healthy development of their children. In tandem, we've created the Maternal and Young Child Health Transformation Center, a center for excellence dedicated to transforming systems to better serve Ohio's pregnant moms and their young children. Finally, you can get involved in this work by joining our Ready, Set, Soar Ohio Coalition. If the future of Ohio's children and our state's long-term success are important to you or your organization, we hope that you will become a member of this coalition to further a unified voice for mothers, young children, and their families in the state of Ohio. And you can join us by visiting readysetsoaroh.org/engage. And thank you, and I will hand things over to Kelly.
Thanks, Kelsey. My name is Kelly Vyzral. I am the Senior Health Policy Associate for Children's Defense Fund Ohio. Children's Defense Fund Ohio is a child advocacy organization that has worked for 40 years here in Ohio to ensure a level playing field for all children. CEF Ohio provides a strong, effective, and independent voice for all children in Ohio who cannot vote, lobby, or speak. We pay particular attention to the needs of poor children, children of color, and children with disabilities. Next slide. I'm not going to spend too much time on this slide because most of this information was already covered. But I will say that, one thing I think on this slide is that Ohio is in the bottom quartile of all states for infant and maternal health. And I know that we can do better than that. Next slide, please. So how do we address these problems that we've heard about that are facing women, especially Black women in pregnancy? And one option is through doulas. Doulas are non-clinical healthcare professionals. They offer emotional, physical, and educational support to pregnant, laboring, and postpartum mothers. Doulas act as an advocate for women who feel marginalized by the healthcare system to make sure that their voices are heard and their concerns are being addressed. They offer important communication between doctors, nurses, and expectant mothers. House Bill 142, introduced by Representative Crawley and Brinkman, would allow the Medicaid program to cover doula services. And as was mentioned, well, maybe this wasn't mentioned, there was also a doula care amendment offered by Representatives Crawley and Brinkman. It was not accepted into the budget in this first House iteration, but we will continue to work on that through the omnibus, and hopefully we'll get to see that in the omnibus bill. Next slide. The other way that research shows us that we can deal with this problem is through a 12-month postpartum coverage. And Kelsey just talked a little bit about this. Currently, the Ohio Medicaid program only covers postpartum care for 60 days. So that essentially is one visit for a mother after she gives birth to see a doctor. Pregnancy eligibility category in Medicaid is 200% of poverty. And then on the 61st day, if she does not qualify under another Medicaid category, she loses her healthcare coverage. So we have that gap in coverage between 138% of poverty where she would qualify for Medicaid and that 200% where she's going to lose it after giving birth. And we know that over half of the pregnancy-related deaths occur in the postpartum period. And we also know that over 50% of those deaths could be prevented. Next slide, please. And as Kelsey mentioned, the American Recovery Plan does add language to cover that 12-month postpartum coverage. So it allows states to draw down those federal funds, and it allows them to add that 12-month postpartum language through their state plan amendment rather than having to do it through a waiver and then go back and have that renewed at a time period, normally 5 years. So we're really encouraging, we're really hopeful that both of those amendments, the doula care and the 12-month, will be added in the omnibus bill. And I am going to yield the rest of my time to the next presenters, which I think are going to be able to really give us a great overview of the work that they're doing and the state of Black maternal health in Ohio. So this is Jessica Roach and Dorian Wingard, and they represent ROOTT.
Hey everyone, good afternoon, and thank you for having us. I mean, this has been an afternoon full of interesting optics and data, so we'll try to see if we can help out here. Again, my name is Dorian Wingard. This is my partner, Jessica Roach. She's the CEO of ROOTT, and I'm the COO, and together we really work to try to get things done at a community level. Next slide, please. So really, we're going to try to breeze through this. We only have about 7 minutes. So if it's rapid fire, forgive us, but I think there's going to be some Q&A time. This slide pretty much identifies for you all what our overview is, what our mission is. So we're a collective of Black families that have started this organization from an interdisciplinary perspective. And our only intention is to deal with health inequity that has impacted Black families and resulted in the maternal and infant mortality rates that we see here now. Our mission is to comprehensively restore the collective well-being through a collaboration, resource allocation, research, and re-empowerment in order to meet the needs of Black parents and families. Real specific, real direct is how our work flows. Next slide, please. Our impact statement here, again, you all can review this at your leisure. But we primarily deal with or work through direct services, which is what we're known for primarily, our perinatal support doula services that have interfaced with families and directly work with families to ensure safe or healthy birth outcomes. This work has yielded a 0% mortality rate for our mothers and our babies since 2017. And we're happy about that. We're humbled by that. But that's really the bottom line of the results of our work. And we get there because we go beyond those surface level risk factors with regards to a lot of the conversations we have about the social determinants of health. We're focused on the structural and the institutional determinants that have led to the adverse or poor outcomes with regard to those social determinants. And we do this because in a way that allows us to work collaboratively with folks who are aligned with our mission. And that's very important because a lot of times folks are out here doing different types of work and it may not be aligned with the mission of being specific and direct to the health inequities that Black families have experienced. And that then creates some sort of conversation that we need to have. But our work is focused specifically on that because of the health inequities. Next slide, please. This slide, and then I think the next couple are just examples of the partnerships that we have been able to garner over the past 3 or 4 years. We are a part of the Merck for Mothers and Safer Childbirth Cities initiatives. We were one of their inaugural groups, the first in the first group of 10 and the only in Ohio at the time. And we've been able to continue to do that work since being allocated those monies. We also do work with the Black Maternal Health Caucus and some of the others and are really wanting to increase that work and make sure that we actually have something tangible that comes out of it. Next slide, please.
So what you see here is just basic overview. It gives us a background of how it is that ROOTT operates, what we ground in, and how it is that we developed our perinatal support doula services, along with our overall principles for our policy and advocacy and our work within our communities. What you see here is what we consider the web of causation and the social determinants. We discussed the social determinants of health significantly. Everyone's pretty familiar with that. This is the easy conversation where you can relate food stability, education, income, neighborhood demographics, housing, et cetera, to Black maternal and infant mortality. But what isn't often discussed, next slide, is the actual impact of structural determinants on health. So when we talk about it from this perspective, it really gives you an opportunity to see that it's not just the social determinants of health. As a matter of fact, with the most recent report from the CDC, we've been able to show and demonstrate that even when certain income levels, education levels are achieved, Black women still have a much higher rate of maternal mortality. And as a matter of fact, that gap has a tendency to grow because we end up being closer to we end up being closer to the structures that actually have created the consequences of social determinants. So when you're talking about professional Black families, we deal with higher levels of stress. We deal with everyday interactivity, those types of things. But when we're taking a look at this specifically, it's really easy to have conversations around housing, but no one wants to really have the deeper conversation about redlining, specifically when we're not talking about it from a historical context, because the reality is that those policies and those those FHA bank loans are still very much steeped in being able to originate home loans based upon some of these original maps and the Homeowners Loan Corporation, which was established back in 1932. Next slide, please. So the reality of this is that we know that without addressing, disrupting, and dismantling the structures of the structures and the institutional determinants, we will not ever be able to address what are considered the social determinants of health. Next slide.
So this is a real quick drive-by on ROOTT as a community-based organization, which is what we are, nonprofit, tax-exempt type, whatever, 501c3 organization. But our focus really is, again, on the full spectrum perinatal support doulas that we train and certify in-house. We typically don't do a train and release type of engagement. The folks that engage us in that way are certified by us in that way and are our employees. We currently have about 19 staff within the organization, and we work across the socioeconomic spectrum. We also provide healthcare provider training, continuing ed. We provide consultation for other CBOs, and we've become either intentionally or unintentionally, subject matter experts in this area with regards to our advocacy at the federal, state, and local levels. And we do that consistently and unapologetically because the stakes are too high to play politics with people, and it's just not appropriate for us to do. We're also active in research and really are okay with the label that we typically get as social injustice activist as a result relates to health inequities that our families face. Next slide, please. This is again like a snapshot of what that full spectrum perinatal support may look like. We also provide breastfeeding education, lactation support. We have CLCs within our organization that are active and available to each family that we see. We are clearly the advocate for that accurate health information. So much of it comes at our families. It would be funny if it wasn't sad. And we make sure that we are the equity advocate in that space too. Our goal really is to make sure that our families have all of the information they can have at that time in that most vulnerable moment so that they can make informed decisions. Some of them we may agree with, some of them we may not agree with. But the point is that the family has the right to determine when, where, how, and if they do any of this. And we support their ability to do so. We also are a home visiting program provider. We have a lot to say about the Help Me Grow piece and the HFA and all that other kind of stuff that we can talk about with any of you offline. But we are a home visiting program provider, and we have integrated that particular function into what our role was before, and it's been able to create a decent balance. Next slide, please.
And so this slide, it basically gives a couple of quotes from both Dorian and I discussing not only what it is that we know in regards to obstetrics and gynecology, is that this was built, this whole practice in and of itself was built off of stolen knowledge and traditions of Black and Indigenous women. Unfortunately, how it was utilized and how it was developed was used against us through means of rape, sexual assault, pedophilia, eugenics, and genocide. We utilize a reproductive justice framework to be able to change that. I think it's important to make sure that we discuss this on that level because it leads to what it is that we're talking about here that Dorian has stated, which race-neutral solutions are impotent in the address of intentional race-specific racism. Consequently, true health equity will certainly change the lives of the oppressed and the oppressor in ways that may lead to the deconstruction of American humanity. Excuse me. Let's be clear about what all of that means. One of the things that we do and one of the reasons that we're here and one of the reasons that we believe that we have the health disparities that we have is because of levels of miscommunication that are still steeped in how it was that Western medicine overall, but obstetrics and gynecology specifically was developed. And so we really are trying to move that needle from having conversations about race being the health risk factor versus actually dealing with racism as the health risk factor. Next slide.
This is our final slide. It's a snapshot of us back in, I think it was 2017. And this is just a small snapshot of some of the families and some of our staff that have become a part of the ROOTT family. It is about 5 times its size now. And we don't know, we're probably going to get a drone to take an aerial shot of us because the camera frame's just not wide enough. Also on this slide, and Kelly, we can probably get this to you all if necessary, if you want it. There is a link to a ROOTT origin story that we did with NPR back in 2019 that kind of chronicles where we started and how we began and how we ended up here where we are. And again, there's a lot of conversation about how to address Black maternal and infant mortality. Again, ROOTT has a 0% Black infant and maternal mortality rate. There's really not a lot of deliberation we need to have on the types of models that work. We just need to figure out what we want to invest in. Thank you all.
Thank you so much to all of our presenters this afternoon. My goodness, I always learn so much on these, and I'm thankful and grateful for your time and your expertise to share with myself and all of folks in the webinar this afternoon. So we do have a couple questions to kick us off this afternoon. We have about 15 minutes, so plenty of time to please feel free to ask those questions within the chat function or the Q&A. We'll be monitoring both. And the first question, I believe, is for Dorian and Jessica. Can you describe how the history of midwives relates to racism? Their experience is that obstetricians will not back up midwives. Is it because historically most Black families have used midwives to deliver their babies?
I don't understand the question, but go
I'm
ahead.
not sure.
I can take this one if you guys.
Apologies.
No, actually, we're fine.
We're trying
This
to,
is actually,
yeah, this is an easy one.
So to be specific about why it is that it's different per state. And so I think that that's really important to note. If we're discussing it specifically for the state of Ohio, there actually is, there's a couple of things that go along with that. One, there's several different types of midwives, certified professional midwives, direct entry midwives, and then those that are certified nurse midwives. And they all practice in different settings. Certified nurse midwives are often backed up by, they're actually within practice, but they're very typically hospital based here in the state of Ohio. While there is the ability to be able to develop a collaborative care agreement, to be able to work in home births and in birth centers, it is very challenging to be able to get OBGYNs to be able to sign off on that collaborative agreement. There's a varying amount of reasons for that. Some of it has to do with insurance liability, which is astronomical in the state of Ohio. Some of that has to do fundamentally with belief systems, other reasons that you could potentially speculate about. Regarding certified professional midwives are technically illegal, meaning they're not illegal and they are not legal in the state of Ohio. They are illegal. So there isn't a whole lot of regulation that happens around that. Not all OBs automatically fire a patient when they have a certified professional midwife. So that's kind of a broad generalization, but there are those that unfortunately don't have enough of the understanding of what it is that a certified professional midwife does, which is really literally only practice with the lowest risk pregnant women that qualify for a home birth. And so it really ends up being best care when you can have some type of work in tandem with an OBGYN. So in the event that there are any type of medically related issues that occur, you have someone that you could transfer care to and develop those relationships. And we've seen those happen across the state. Now, very specifically to the question in regards to the history of midwives, that's a much broader question. It's actually work that we've done in research and published work, and I steeped in the tradition and trained by Black midwives. There is a huge history that comes along with that dates all the way back to the Shepherd-Townend Act, which actually, in essence, eliminated Black midwives. It took the number, like in Florida, state of Florida, from 4,000 down to 18 over a decade because of certain stipulations of regulation that went into policy. That was supposed to expand the access to midwives, but really was only directly related to white midwives, and ended up rendering Black midwives, Indigenous midwives, as illegal. So they were no longer able to practice in that way. As far as whether or not that has to do with the historical of most Black families had midwives, well, most Black families had midwives because we weren't permitted into hospitals unless it were specifically Black hospitals that we were able to have access to. So the challenge now really has to do with, I think, a lack of information, a lack of understanding. And again, those power dynamics that we're talking about that really have to do with the structural determinants of health that are creating these social consequences. Hope that helped with giving you some type of overview.
Great, thank you so much, Jessica and Dorian. So I have a question for, I believe for either for Hope or Kelsey and Kelly. So you mentioned House Bill 142 was an opportunity, kind of a specific doula bill within the legislature right now. Other than the provisions in the budget bill, are there any other kind of standalone health bills that are kind of in the hopper or introduced in the legislature that you all are working on?
It looks like Kelly is talking, but she's muted.
Oh, sorry, Kelly, you are muted.
Hope, if you're following anything, go ahead. I'm looking something.
No, we're mostly just following 142.
Well, and Kelsey, while you mentioned that, I mean, we are definitely have been working lockstep with Rep. Crawley on this piece. And, you know, Kelsey may remember some of that in her prior days as well. But, you know, it's gotten to a point to where the bill is viable, but it still has, it's not a perfect bill. No bills are. But this one particularly has a glaring issue in it that could potentially be problematic, and that is housing this whole doula advisory board under the Department of Nursing. I mean, that is something that we, you know, we have a problem with it. We support the movement of the bill, but that's not exactly the most optimal scenario for us. And in our opinion, we think would be most beneficial. We think it should be a standalone body that should be managing and regulating this particular field as it supports families, and not being co-opted in a way or enculturated in a way by a department that may not be as friendly to it as it should be.
So I think some of the other bills that we're watching at Groundwork are House Bill 42, which is the Enact Save Our Mothers Act, House Concurrent Resolution 6, Declare Racism as a Public Health Crisis, and then of course 142, and I'm blanking on the other bill number, but regards, and then there's companion bills in the Senate as well, but regarding PMR, Pregnancy Associated Mortality Review Board. But those are the other bills that we're watching, and those all speak to these issues and improving health outcomes for women, specifically women of color.
Great, thank you, Kelsey. So still monitoring the chat for any additional questions from our attendees, but wanted to pose a question to all of our presenters today. So if folks, attended our webinar today, have heard about maternal health and Black maternal health struggles and efforts within the legislature or within their communities, what is the best way that they can become involved? How would they kind of search for those resources, and how can they add their voices to the conversation?
How can they help?
And their support.
Jessica and Dorian, did you guys want to go first?
Sure. What you got?
So how can you help? What is the best way to be able to help? I think that it's really one of the ways that we discuss that is important to help is really addressing what is the overall inequity in funding for certain organizations, especially when those organizations are actually showing the levels of results and outcomes that we're trying to achieve across the state and obviously across the country as well. This is a consistent conversation that comes up with our colleagues across the country. So addressing inequity in funding is one of the ways. The other is actually, we have a significant amount we have some challenges here locally, more than we do nationally, as far as being viewed as those subject matter experts. And so a lot of decisions end up being made, but there hasn't really been a consultation with those that are deeply engaged in the work and in a direct way. And so we would welcome that continues to happen, but also in itself is an equitable way as well, recognizing that community-based organizations do also a significant amount of work as far as their levels of consultation. A lot of times we're tapped for this intellectual property or the information that we carry, but then there isn't necessarily a development of a relationship beyond that. And it's really important to recognize that there can't necessarily be a duplication in models, especially when you have Black-led organizations that are very specifically dealing with very specific issues that involve our communities, that it's important to not just come to us for the information and the how-to or how have you done it, but to really understand that it's time for our types of organizations to really take the lead, to be able to produce a more of a scalable and replicable model.
And I'd only add to that, I mean, the other ways is really understanding what the work is, paying attention to who produces outcomes, who has those outcomes, what the efficacy of those outcomes are, asking the question of those major stakeholders, hey, you got a model here, why aren't you using it? Why aren't you investing in it? It's a real simple question, and the answers probably are going to be interesting to you. Also, the screen is blocking my thing here because Jessica's reading stuff. So with Hope, we would love to work with your organization to really put out research about the efficacy of the model that we have. Clearly, folks either don't know about it and need more information about it, but it's pretty clear how effective our approach has been to addressing this particular issue. And we stand by it and would love for that to be more of a larger conversation moving forward.
Kimberly Dent just asked a really interesting question.
Kim Dent, I haven't seen Kim Dent in forever. What's she asking?
What is the opinion regarding where fathers fit in the definition of family structure? That's an interesting
I love that
question. I appreciate your question. We don't actually operate in a silo, which is why we say that we're a Black family-led, community-based organization.
And
So
we're
it's really,
sitting here.
and we're sitting here. So the representation that you see here very much is a representation of what our families are, how that's reflected, and how we ground in our approach to care, including the level of advocacy. So we don't necessarily do specifically fatherhood initiative. We don't specifically do motherhood initiative. We do family tree and village initiative. So that it means that we involve both mother and father in all aspects of care. And then also include, when there's times and considerations, that extension, because obviously we know that culturally in our families,
Right.
we have the grandmothers and we have the uncles and we have the grandfathers that may also serve particular roles. And so we're very open to making sure that all levels of communication are addressed in that way, and that the advocacy extends so that the healthcare providers understand as well that you can't just pass over the father when they're in the room. If they have a question, you actually have to address their question. And that certain conversations need to be very clear that those are conversations that are had between partners, not necessarily the decision of the healthcare provider themselves. What county is Frank? We're in Franklin.
We're in Franklin
Thanks,
County.
Hope.
Yeah, we're in Franklin County. Thank you. And Kim, we'll be there to see you soon.
All right, thank you. We have another question open to any panelists to answer, to chime in on. It says, recently the state has been reluctant to recognize systemic racism and declare racism as a public health crisis. In December 2020, the governor created the Eliminating Racial Disparities in Infant Mortality Task Force. If ROOTT and other organizations have achieved 0% mortality rates, which is incredible, does that open the door to a serious discussion about the state government pursuing changes to those structural determinants of health in order to truly reduce and eliminate infant and maternal mortality morbidity?
We don't have an answer for that.
You can ask the governor.
You need to ask the governor that question. I mean, we keep creating task forces, we keep having commissions, we keep having caucuses. Go ahead. It should. Let's say it that way. It should.
But it hasn't.
But it hasn't. And we're several years into this thing, and we keep swirling around the same questions, and we don't need to, but we keep doing that. And we keep throwing TANF funding at things, and that just is a stereotypical fiscal response. Everyone who's experiencing this isn't a TANF eligible family. And so when you're really looking at a comprehensive, more structural and systemic approach, you got to deal with that from the top all the way through to funding. And so, I hope that the outcome of that committee is productive, and we entertain any type of conversations they'd like to have, but your question is timely, and we appreciate it.
So I wanted to jump in with some other ways that people could get involved. Another way is definitely to show up to the State House and make your voice heard. I threw in the chat our advocacy page for Groundwork Ohio, so you can visit there. We have action alerts and things that you can get involved in. But always, public testimony is always a thing. You can provide written testimony, in-person testimony. Make sure that the legislature knows what your priorities are as citizens of the state of Ohio.
Yeah, on that note, if I could, I had a list, and Kelsey is going to provide the slides afterwards, but of just like local organizations like ROOTT and like BBC and Queens Village and Cradle Cincinnati, and these like local, as I mentioned, like these communities have taken matters into their own hands. Like Dorian and Jessica said, they've had to, because there's no time to wait or waste on the state, on another task force, on another council, and people are dying, women are dying, babies are dying, and so this isn't a fundraiser pitch, but they always can, appreciate some help financially or otherwise, I'm sure.
And I just add to that, making sure that the narrative is an honest, transparent narrative. And what we do so much, and it happened here in Franklin County, 5-year reports are released and aggregate data is shared. A little bit of disaggregated data is shared, and everything is just pushed aside on the shelf and hidden. We can't have those kinds of conversations. We really can't. This work requires direct service, not weekend baby showers. It requires direct service, and we have to engage that with consistency. And then those other things are support bases to that. But it requires direct service to stand in that gap with regard to providers, systems, and things like that. And we have to continue to do that work that way.
All right. Thank you so much, everyone. Again, to all of our presenters for your time, your expertise, and for the work that you do. To go ahead and close out our time together today. And thank you to, once again, our presenters and our participants today on a Friday afternoon. We will be back in 2 weeks, again at 10:30 a.m., a little bit earlier, to talk more about really what's in that sub-bill and continue to provide updates from our previous webinars and ways to get involved. Again, encourage you to get your voice out there, and we'll make it as easy as possible. With that being said, thank you again. Have a great, safe weekend, and we'll talk to you soon.
Kelsey, it's good to see you again. Bye-bye.